I'm Dr. Althea O'Shaughnessy. I'm one of the board members for the Colorado Fertility Advocates and a board certified reproductive endocrinologist at Conception's Reproductive Associates in Littleton, Colorado. And I want to thank all of you for joining us this evening. Disparities in access to reproductive care is such an important topic that is not adequately recognized in our medical community. My hope is that our webinar this evening which features experts in the field of reproductive medicine, will spur further discussion and action amongst those who provide fertility care. Our first panelist is Dr. Tarun Jain. Dr. Jain is a board certified reproductive endocrinologist with a very impressive list of distinctions in the field of reproductive medicine. Dr. Jain is an associate professor at Northwestern Feinberg School of Medicine and the medical director of the Northwestern Fertility and Reproductive Medicine Division. Dr. Jain is recognized for his work on the impact of mandated insurance coverage on IVF utilization and outcomes, and he has also published research that explores the racial and socioeconomic disparities in care of infertility patients. Today, Dr. Jain will be discussing disparities in assisted reproductive technologies, access, and outcomes in the US. Dr. Jain?
Gosh, thank you.
Away.
Thank you so much. I'm just going to share my screen. There we go. All right. Well, thank you again so much for the invitation and that too kind of an introduction. But it's really a pleasure to be here and to talk about this super important topic. So I'm going to focus on two areas: disparities in ART access and outcomes in the US. So first, let's just start off with the disparities in access piece. So there's a lot of good news in our field. The field has been growing dramatically from the early 1980s onward. These are the number of IVF clinics in the US. So there's been tremendous growth, as we all know. The number of IVF cycles being initiated annually has been increasing steadily as well. Nearly 400,000 IVF cycles being done annually just in the US. And hence the number of live-born deliveries and from IVF has increased as well. Nearly 80,000 babies born annually from IVF in the US. And the practice patterns have improved. So the percentage of singleton live births has been improving. So we've done a really nice job with guidelines on number of embryos to transfer, better technologies, better techniques, so we can have success with a single embryo the majority of times. So the twin rates and certainly the high order multiple rates have decreased dramatically. So a lot of good stuff in our field. Of course, the one major problem that continues to haunt us is that IVF is primarily a privately funded treatment. Most health plans really exclude it from coverage on all different reasons, whether saying that it's still not medically necessary, this is elective, or it doesn't have proven efficacy, or infertility is a pre-existing condition, all kinds of reasons. And even the Affordable Care Act did not require coverage for fertility treatment, unfortunately. This, of course, is in contrast to most major developed countries in the world, which actually have provisions in their national health policies to cover fertility services, including IVF, and that list is long. And here's many of the countries listed here. So the average cost we know is very expensive for an IVF cycle, roughly about $12,000, and then you add in the medication costs, which can range from $3,000 to $8,000. So we're talking like easily like $20,000 for just like one IVF cycle, and we know often one is not enough. Patients often need multiple cycles to have success. So how does this compare to the average US household income? So the US Census data tells us the average household income is roughly about $70,000. So it's very easy to see that a $20,000 treatment that may require multiple treatment cycles is going to become very unaffordable for the average household. And then let's break down that household income even further by race. So this is Census Bureau data tracking over many years from the 60s to almost current 2019, broken down by race, ethnicity. And as you can see, like certain households, certain groups have an even greater disadvantage. Hispanic and Black households have a lower median household income compared to Caucasian and Asian households. So it puts them at an even greater disadvantage on average. Fortunately, there has been good news in the sense that there are some states that have actually enacted laws requiring insurance companies to provide some coverage for IVF. And currently there's 6 states that have really excellent mandates: Connecticut, Illinois, Maryland, Massachusetts, New Jersey, and Rhode Island, what I call comprehensive coverage, even though there are exceptions in those laws. So one of the early things that we wanted to look at was, well, if insurance covers IVF, is that associated with higher use of IVF? In other words, if this expensive thing is now covered, are there going to be a lot more people able to access it and use it? Of IVF broken down by partial mandate versus complete mandates. And the utilization rate we defined as the number of IVF cycles per 1,000 women of reproductive age. And in the comprehensive mandated states, the utilization was nearly 3 times greater for IVF than in non-mandated states. So there's clearly more people using IVF when it was covered, which makes sense. We redid this analysis and published it recently in AJOG. We used 2018 data, and we found something very similar, but the utilization was overall higher. So in comprehensive states, the utilization was 6.2 cycles per 1,000 women, and in non-mandated states, it was 2.7. So again, about a 2.5-fold higher utilization of IVF in mandated states. So the next question that came up is, okay, so if more people are using IVF in these mandated states, is access equal? So is there an equal representation of the population accessing fertility care now in those mandated states? This pilot study to look at this back when I was a fellow in Boston, and Massachusetts, again, is like a excellent mandate. So we did a questionnaire, 1,500 consecutive women who presented for fertility care at Brigham and Women's. And there were several satellite offices as well. So this practice could potentially capture a good segment of the population in Massachusetts. And we compared the demographics of this fertility population to the Massachusetts general population. And what we found was interesting in that the Hispanic population was underrepresented in the fertility population, as you can see, compared to the Massachusetts general population, whereas Asian patients were overrepresented demographically. As far as education, the highest level of education, the fertility population, nearly half of them had an advanced college degree, a master's or a doctorate level degree, compared to 12% in the general population, so highly educated. And then as far as annual household income, 60% had an annual household income over 100,000 compared to about 18% of the general population. So really, this was like a wealthy, highly educated population, not very representative of the general population. Well, what is the prevalence of infertility? Does it vary based on ethnicity? And this is looked at by the National Survey of Family Growth very regularly. It's like a survey that the government puts out to nearly 12,000 married women of reproductive age via in-depth interviews. And the prevalence of infertility is not dramatically different across ethnicity. White, Black, Hispanic, very similar. Interestingly, Asian patients tend to be a little bit lower in terms of reporting infertility, but tend to be overrepresented in terms of accessing treatment. Education, no different. Looking at the military population. So it was called an equal access to care setting because people in the military can access fertility evaluation and affordable IVF cycles. So this was done at Walter Reed, and they hypothesized that access should be equal in such a situation where things are covered in the military. But they also found that Hispanic women were underrepresented, the ones who were seeking IVF treatments, underrepresented compared to the general overall Department of Defense population, and Asian women were overrepresented. So to try to better understand this, we did a pilot we published this back in 2011, did a survey of patients accessing fertility care in Illinois of 1,350 consecutive women. Got a good response rate, 743. And we asked a bunch of questions to try to dive deeper into what differences may exist. We found that there were differences in the distance traveled. Black and Hispanic respondents traveled much further to seek care. The referral patterns were different. Black women were more likely to be self-referred. Hispanic women more likely to be referred by friends or family as opposed to by a physician. They also reported that it was more difficult to find a doctor who was comfortable, who they felt comfortable with, or more difficult to get an appointment or to take time off work. And Black and Hispanic women also were more worried about several things compared to white women, as far as social stigma, use of science or technology, the side effects behind treatments, the risk of multiples, miscarriages, ectopics, and birth defects. These are all greater concerns. So greater fears. An interesting study done by Emily Youngheim when she was in WashU. Of course, she's our division director now. So they looked at patients who had done their first IVF attempt at WashU who did not have a live birth, did not have success. And they found that Black women were more likely to discontinue treatment, meaning like not come back, not do anything more, 3 times more likely to not come back. Or they return more slowly, more likely to return slowly for treatment. And this was regardless of insurance coverage or income. So something is also preventing them from coming back. We did a more recent up-to-date study to better see what the current climate is. And we did this at Northwestern. We conducted a questionnaire of 5,000 consecutive women who presented for fertility care at Northwestern. Got a good response rate, and our non-respondent demographics were similar to the respondents. This is the geographic area of all our respondents. And we captured a good segment of the Chicagoland area and all areas, including some parts of Northwest Indiana and a little bit of Wisconsin as well. And we have 2 other satellite offices besides the main office in downtown. So we felt like we got a good representation. And we first looked at the demographics of our respondents. And here again, in the bottom, we find that predominantly the patients seeking care tend to be white, 72%, compared to about 51% in the general Chicagoland area. And Black patients are underrepresented, 7% versus 29%, and Hispanic 5% versus 9%. So, and Asian patients overrepresented, 10% versus 6.7%. So very similar to what we found in Massachusetts. Education, again, like master's, professional degree, 60%, very similar to what we found in Boston, highly educated. Annual household income, nearly 90% had a household income over $100,000. So highly educated and wealthy in a great mandated state. So some other interesting findings. Also, not unlike what we found before, Black and Hispanic women travel twice as far compared to white and Asian women. Black women were more likely to report their race was a barrier to getting treatment, and Black and Hispanic women reported twice as likely to report their income and body weight were barriers. Furthermore, 42% of Black women reported that their physician did not understand their cultural background, compared to 16% of white women. And Hispanic women were very or extremely worried about the side effects of treatments. So again, similar findings as what we saw from our Massachusetts study. Also, interestingly, we asked if they believed that if stress can cause infertility, reduce success with treatment, or cause miscarriages, trying to understand the belief patterns, because we do, from what we know, we don't think that stress causes these things. But what do people actually believe? And perhaps this may be holding them back in some way. Interestingly, we found that Black and Hispanic women were more likely to believe that stress can cause infertility, reduce their success, and cause miscarriages. So just to summarize, mandated coverage certainly improves access and utilization of fertility treatment, but major disparities continue to exist. There's certainly a large untapped population of infertility patients out there who really need care, and we need creative solutions to improve their access, and we have to pay attention to the cultural barriers and fears. I'm trying to be mindful of time as well. Moving on to disparities and outcomes, there's tons of disparities all across medicine and healthcare, ranging from, in the cardiac space, Black patients are less likely to be referred for cardiac catheterization if they have heart disease. Hispanic patients are more likely to not get pain medication for bone fracture in the emergency department. They're all like really good studies showing all this stuff. Or Black patients on dialysis are less likely to be referred for kidney transplantation. In obstetrics, tons of disparities exist. Black women are 2 to 3 times more likely to die from pregnancy-related causes. Mortality is much higher. Life-threatening events are much higher for Black women, more likely to be readmitted for complications as well, and certainly higher rates of preterm delivery and neonatal mortality. In GYN, again, major disparities as well. Black women are twice as likely to undergo open surgery when it could be done laparoscopically, more likely to have complications from simple surgeries, more likely to die from cancer, breast cancer, and ovarian cancer, when everything else is similar. Ectopic pregnancies are treated differently as well. So lots of disparities. So how about in our space, in the IVF space? Unfortunately, the news is not so good. This was the first study. I just wanted to show that this was the first study that actually highlighted the differences in outcomes. It was a very small study, retrospective analysis comparing 95 patients versus 37 patients in a University of Maryland practice. And they found that in this very small sample, Black patients had a lower implantation pregnancy rate and lower live birth rate compared to white patients. But fast forward, there were couple of other smaller studies along the way with small sample sizes until David Seifer examined the SART data to get a larger sampling. So this was analyzing data from 99 to 2000 national SART data. But one of the problems that exists is many people don't report race in the SART data. So there's lots of cycles that get excluded because there's missing data on race. But regardless, they were able to assess about 2,000 cycles of Black patients who did IVF. And what they found was that these are fresh non-donor cycles, first attempt. The pregnancy rates were lower in the Black population, miscarriage rates higher, and live birth rates were lower. In that same 99 to 2000 data, another group assessed Asian outcomes and found that Asian women had lower clinical pregnancy rates and live birth rates compared to white women as well. A couple of years later, I was part of a SART working group where we looked at data from 2004 to 2006, but we also we looked at all ethnic groups, Asian, Black, and Hispanic. And this, again, there was a lot of missing data on race, but based on what we certainly had better numbers than the prior analysis, and we found a significantly lower odds of live birth for Asian, Black, and Hispanic women compared to white women. More recently, David Seifer looked at 2014 and 2016 outcome data, SART outcome data, and still found the same, something very similar. Black women had a lower odds of live birth. He only looked at Black versus white. So the big question of why, I think there's a lot of work to be done. There could be many reasons, and we need to figure this out. There could be anatomic or biologic differences. Are there differences on endometrial side, on the microbiome, BMI, fibroids, tubal disease? Are there genetic factors, the rate of egg depletion, or hormone synthesis issues or differences that need to be figured out? Environmental factors, dietary factors, use of things like smoking, caffeine use, are those factors, psychological factors. So there's a lot of work that needs to be done, but certainly there's mounting data that outcomes are certainly different based on race, ethnicity. We need more work. Really important for our practices to collect and race ethnicity data so we can keep tracking this and trying to better understand it. And last slide, this is just kind of putting it all together. Ultimately, there's so many factors at play. We call this our hypothesis, disparities in ART hypothesis. So whether it be delays in obtaining ART for all various reasons, whether in the upper left, economic, cultural factors, personal beliefs, structural factors at play, whether it be higher patient dropout, as we've seen, like could it be lack of diversity of REIs, worse outcomes, limited locations of clinics, perceptions not being understood, or then could it be different biological factors that we talked about, and also provider factors, certainly implicit biases that exist amongst all of us, cultural competency, language barriers, lack of, again, diverse providers. So lots of work, lots of things and work to be done. So I will stop there. I hope I've not gone too much longer than I had the time
That was
for.
perfect. Oh, perfect. Thank you
Cool.
so much. Very comprehensive. We do have a lot of work to do. So that's for sure. So I'm going to introduce our next speaker. That is Dr. Allison Komorowski. She is a fellow in reproductive medicine at Northwestern University. One of her special interests is disparities in access to reproductive health care. She has published research surrounding this important topic, and today we'll be discussing disparities in access to reproductive health care in the Hispanic community. Dr. Komorowski.
Thank you so much for that introduction. I'm going to be speaking mostly about disparities for Hispanic patients based on a review that Dr. Jain and I published. So just a little bit of background. Next slide, please. Impaired fecundity affects several women in the United States, somewhere around 7.4 million, which corresponds to 12.1% of reproductive age women. By the 2019 U.S. Census Bureau population estimate, people of Hispanic and Latino ethnicity comprised 18.4% of the U.S. population. However, as Dr. Jain alluded to, Hispanic women have lower rates of use of infertility services than non-Hispanic white women. There are many potential barriers that could impede access to infertility care, including geographic, economic, cultural, and societal barriers. Next slide, please. A large national survey of over 10,000 reproductive age women that was done by the National Center for Health Statistics in 1995 found that Hispanic women actually reported infertility more frequently than Caucasian women. However, more recent data has showed a similar prevalence of infertility across racial groups, but we do know that Hispanic women are underrepresented in the population that receives infertility treatment compared to the demographics of reproductive age women. Evaluation of the SART data from 1999 to 2000 from over 80,000 patients revealed that Hispanic patients comprised only 5.4% of the population receiving assisted reproductive technology. And based on another survey from 2002, a survey of family growth nationally, 15% of white women between 25 and 44 had sought medical help to get pregnant, compared to a much smaller 7.6% of Hispanic women. Next slide, please. A cross-sectional survey of Midwestern infertility patients conducted from 2004 to 2005 attempted to identify cultural factors that contribute to disparities. Dr. Jain alluded to some of these factors. Hispanic and African-American women had been attempting to conceive for 20 months longer than white women, which is a significantly longer time period. And they additionally were more likely to be nulliparous when presenting for infertility care. Dr. Jain alluded to these factors, that Hispanic and African-American women were more likely to find it hard to find a physician with whom they felt comfortable, to get an appointment, to take time off work for their appointment, and to pay for treatment. And importantly, Hispanic and African-American women reported it was more difficult to get treatment because of their race or ethnicity. Next slide, please. Hispanic women were also more likely to report significant concerns about needing to consider adoption as an alternative to treatment, about friends or family finding out about their treatment, about using science or technology to conceive, about side effects of treatment, having a miscarriage, having an ectopic pregnancy, or having triplets or greater. And similarly, a telephone survey of American women that examined factors involved in reproductive choice and fertility found that Hispanic and Black women had higher infertility stigma scores, as well as more ethical concerns surrounding infertility than white women. Next slide, please. A cross-sectional study of 1,460 women seeking fertility care at an academic center in Illinois, which, as Dr. Jain mentioned, is a state with mandated insurance coverage for fertility testing and treatment, found that Hispanic women traveled twice as far as white and Black women, and Hispanic and Black women were twice as likely to report their income level and weight as barriers to treatment. Next slide, please. Additionally, Hispanic women were more likely to report that emotional stress could reduce the success of fertility treatment compared to white women, and were also more likely to, less likely to have had genetic carrier screening, which is recommended to be a standard part of preconception care than white women. Only 49.4% of Hispanic patients with infertility had had genetic carrier screening performed. Additionally, Hispanic patients were less likely than white and Asian patients to agree that leftover embryos being used for research is something that should be allowed. Next slide, please. Regarding financial barriers to care, in 2003, Dr. Jain's study, as he described, looked at patients receiving access to care as mandated in insurance coverage for infertility services came available in Massachusetts. And there was a significantly lower proportion of the Hispanic patients presenting for infertility care compared to the state population of Hispanic patients. Additionally, the study in that equal access to care model, which was described for use of ART in the military healthcare system, found that while Hispanics comprised 9% of the Department of Defense population, they comprised only 4% of the ART population. And in this group of the Department of Defense population, education and language barriers are considered less likely, given that a very small proportion of the Hispanic members of the Department of Defense had not completed high school, and as active duty service member requirements require that at least one member of the Hispanic couple be English speaking. Next slide, please. Additionally, a study was done after a large employer in Michigan expanded IVF coverage to their healthcare plan employees, which was 18,000 enrollees. And the absolute rate increase in IVF use among Hispanic women was the lowest in all of the racial groups studied. the absolute rate of increase in IVF use as insurance coverage expanded was only 27.5% in the Hispanic patients compared to nearly 65% in the white women. And the findings of all of these studies together demonstrate that lower use of ART among Hispanic women is unlikely to be driven solely by economic factors, and that other social and cultural factors may be contributing. Next slide, please. I want to describe a little bit about strategies for improvement. Improved insurance coverage for infertility evaluation and treatment may encourage more patients to seek care, and it may eliminate some financial barriers for patients. But we also need to ensure that patients have better access to primary care and general gynecologic care. This is crucial because many causes of infertility can be prevented if caught early. For example, obesity and sexually transmitted infections, if found early, prevented, and treated early, can lead to reductions in infertility and tubal factor infertility rates. Hispanic women in America have historically had lower rates of cervical cancer screening through Pap smears, and this has seen improvements with the expansion of Medicaid coverage. And since many general gynecologists refer their patients to REI specialists for infertility evaluation and treatment, having access to general gynecology care is the critical access point for patients to access infertility care in the future. Next slide, please. Additionally, educational programming for patients is important because this can help to address the causes of infertility for patients and destigmatize infertility as a medical condition. Hispanic women may perceive more social stigma surrounding infertility based on the studies I described, and they may have more ethical and religious concerns about ART treatment. Some authors have hypothesized that a major factor in reduced ART utilization rates among Hispanic patients is the lack of fertility information in commonly used Spanish media and social networks. So educational materials for patients should emphasize that infertility is a medical condition, that evaluation and treatment are available, and that IVF is not the only treatment option available. Next slide, please. As far as physician education goes, education on implicit bias, cultural competency, and providing care to multicultural populations could serve to improve the patient experience. Many providers may be unaware of their implicit biases and the role that they play in perpetuating health disparities in their fields. Patient satisfaction, treatment adherence, and health outcomes can all be optimized by effective patient-physician communication. However, patients of minority background may have worse satisfaction with physician communication than white patients. Providers who receive education on barriers and access to care and common fears about ethical and religious concerns for ART treatment may be more able to effectively communicate and advise minority patients on their treatment options and address their specific concerns about ethics and religion. Next slide, please. Finally, there remains significant lack of minority representation in the physician population, which is not reflective of the general US population. The majority of active physicians identify as white, greater than 50%, followed by Asian, with much lower proportions identifying as Hispanic and Black or African American. Within OBGYN, minorities remain underrepresented, with 9.6% identifying as Black and only 6.7% as Hispanic. Within REI as a field, a survey of members of the Professional Society for Specialty Trained Physicians found that most REI physicians identified as Caucasian, 76%, with only 6% identifying as Hispanic and 3% as African American. To improve these disparities, residency programs need to actively seek to recruit underrepresented minority applicants and offer second visits to these applicants, and institutions should address diversity in their hiring practices and seek to advance women and underrepresented minorities into leadership roles to improve these disparities. Next slide, please. In conclusion, Hispanic women receive disproportionately lower rates of infertility treatment. As Dr. Jain described, Hispanic women may experience worse IVF outcomes than non-Hispanic white women, and addressing disparities in infertility care in the Hispanic population will require a multifaceted approach. This may include expanded insurance coverage, improved education for patients and providers, and further research on the barriers to care. Thank you so much.
Well, thank you, Allison. That was great. And I like that you offered some ways that we can address this issue that are comprehensive, right? So I think we all need to be aware of that. Our next speaker is Dr. Lisa Greene. Dr. Greene is a board-certified reproductive endocrinologist and is one of the associate program directors for Prisma Health Upstate OBGYN program in upstate New York. She's also the chair of the Diversity, Equity, and Inclusion Subcommittee of Prisma Upstate Medical Education Committee. Dr. Greene's clinical interests include fertility preservation for survivors of cancer and health disparities. This evening, Dr. Greene will discuss disparities in access to fertility care in the Black communities and explore the possible causes for these disparities. Dr. Greene?
Thank you so much. I really do appreciate such a kind introduction. I put together my talk and my PowerPoint slides. I had a moment of panic yesterday when I looked to see the speakers and I realized Dr. Jain was going to speak first, and that I had cited him numerous times in my talk, and I felt that, rightly so, there was going to be a lot of overlap in what we were going to say. And as I listened to Dr. Komorowski and Dr. Jain, absolutely, we're going to say very similar things. And so forgive me if I'm repeating what has already been said in some of my comments here, but they did a wonderful job of just really highlighting some of those disparities that exist in terms of access to care. And so the National Academies of Sciences, Engineering, and Medicine, which we formerly called the Institute of Medicine, they define access to healthcare as this timely use of personal health services to achieve the best possible healthcare outcomes. And so when we think about barriers to access, we're really thinking about several things, and we want to put them into little buckets. And so there are the financial barriers. Here in the United States, there's the psychological barriers, and we'll talk about that, the cognitive barriers, and which structural institutional barriers prevent us from having the best overall outcome for our patients. And so these all lead to, in a culmination of things, late presentation, a decrease in the quality of the care that we're able to provide, and patients failing to seek services at an adequate time interval, or even prevention of things happening in the future. And so I want to talk a little bit about those financial barriers. And I know some people have mentioned some of these exact same statistics, but we're talking about those that are, non-insured or underinsured. So the cost of fertility services here in the United States is a really significant barrier for most families. Unfortunately, the vast majority of our patients are seeking to, or having to have to pay self-pay for their fertility services. And Dr. Jain mentioned that we have multiple states that are going to have coverage mandates. And I believe there are 15 states that have mandated coverage, and there are about 2 states that have a mandate where insurance coverage has to be offered to patients. But still, there's a significant gap there. And the majority of our patients are coming out of pocket to pay for their fertility care services. And in one study, that's really important, because in one study, the median per person count of how much somebody would pay in 18 months ranged from as low as $1,100 for medications only to as much as $38,000 for a donor egg IVF cycle. And here in the United States, the average cost of an IVF cycle can range anywhere from $12,000 to $17,000. And so, as Dr. Jain mentioned, in 2020, the US Census looked at the median household income, and they found that to be somewhere around $67,000. And that mean income for non-Hispanic whites is $74,000. But when you look at our non-Hispanic Black women, that's $45,000 is essentially what that median income is. And so at a cost of about $12,000 to $17,000 for a IVF cycle, we're talking about a little bit more than a third of the average household incomes of our patients. So as Dr. Jain mentioned as well, in Massachusetts, which is a mandated state, they have a coverage mandate. More than 60% of the infertility patients had an annual household income above $100,000, so greater than that national average. And that is in comparison to only that population representing 17% of the state. So finances are going to be the largest and a significant barrier for a lot of people, but there may be a disproportionate effect for women of color, and Black women notably. So there are those psychological barriers, right? So Dr. Jain mentioned this a little bit. There's the stigma, the mistrust of the healthcare system. So there are numerous cases throughout history of these injustices that have been done. to the Black community. And so there's a Tuskegee study, there's involuntary sterilizations, there's Henrietta Lacks, there's just numerous things that have led to a little bit of mistrust in our healthcare system. And we have more recently data about COVID vaccines, right? So this just continues to highlight the continued disparities and the discomfort and the mistrust in the healthcare system that perseverates. And how does that kind of bleed into our fertility care services? So as Dr. Jain noted earlier, African-American women find it difficult to find a physician with whom they feel comfortable. Now, as he stated, is this due to a lack of diversity among providers? And I think Dr. Komorowski said the same thing, or is this a mistrust of the system? There still is this significant stigma when it comes to women of color and Black women notably. Growing up here in the United States, and I'm a Black woman myself, you've heard these stereotypes about your group and, relate to high rates of teen pregnancy, hypersexualization, hyperfertility. Many people don't talk about what their experiences have been and how that can cause some women to feel that they're alone in their situation and feel isolated and feel that this is only happening to them. And that perhaps this infertility is some type of reflection of their character, or their inability to become a parent. So there was a study by Mismer et al. Where they mailed a 24-question survey to about 1,300 women who came to the University of Illinois for fertility care services between 2004 and 2005. And in this study, what they noted was that there was significant social stigma of infertility. And that was very concerning. It represented about 49% of the patients in that study. And that Black women were more likely to be concerned about this when compared to white women, threefold. So also in that study, they noted that African-American women were significantly more concerned than compared to white women about the potential for poor pregnancy outcomes. Maternal morbidities and everything that we know to be disparate about what happens when Black women are pregnant and they go to deliver their babies. This is about multiple pregnancies, spontaneous abortions, miscarriages, ectopic pregnancies, and birth defects is what they included in that study. And then there are the cognitive barriers. So that's the low level of healthcare literacy for some people, the use of traditional medication, self-treatment, lack of preventive measures in general. All of these can lead to poor healthcare outcomes. And health literacy, we know, is very important. It's important to understand your health and how to navigate the system. And there are some significant racial and ethnic disparities that exist there. So historically, infertility care has been accessed disproportionately by non-Hispanic white women who have higher educational attainment and a higher socioeconomic status. And I mentioned the median income earlier. So for example, just not to pick on Massachusetts, but in their study, none of the infertility patients had less, or in that state, less than a high school diploma, when compared to 15% of the state's population actually fallen into that bucket. And in the study that was mentioned by Dr. Jain earlier, 49.6% of the infertility patients, so almost half, had advanced degrees when compared to only those, or that population representing 12% of the state. So now if you look and you consider the why, is it perhaps that highly educated women are delaying childbearing longer? And is this causing this disparity? Or perhaps is there a difference in prevalence compared to Black women or non-Hispanic white women? And actually, interestingly enough, that's not the case. So the National Center of Health Statistics noted that Black women reported infertility more often than Caucasian women in their study, and that was 10.5% compared to 6.4% respectively. Also, they noted that women without a high school diploma had a higher prevalence of infertility than women with a bachelor's degree or higher. So also in that cognitive bucket, we know that Black women are more than 3 times as likely to report race as a barrier. And I think Dr. Jain mentioned this as well, to seeking infertility care compared to Hispanic or even Asian women or non-Hispanic white women. African-American women are also 5 times more likely to be self-referred. So compared to white women, African-American women have been attempting to conceive 20 months longer. And there's some barrier there in getting them in the door. There's something that's holding them back in seeking care. And the why, we mentioned a couple of things, but we don't really know the why. Is it a gatekeeper? Is it a lack of referrals? significantly lower rate of live birth. You know, we sit somewhere at 16.9% compared to 30.7%, and that's when compared to white women. So Black women have been noted to have a higher miscarriage rate. That was also mentioned at 28.9% compared to 14.6% respectively. So in addition to the financial, cognitive, psychosocial, or psychological barriers that exist, you know, there are notable differences in our diagnoses and our reproductive conditions amongst our populations. And so Black women are 2 to 3 times more likely to have uterine fibroids, as was mentioned earlier. And when it comes to being diagnosed with chlamydia or gonorrhea, both of which can lead to significant tubal disease and lead to increased ectopics and also increased infertility, whereas Black women have a six times higher rate of that diagnosis. And when we think of overall healthcare markers, there are disparities that exist in our communities or in these communities. So Black women are more likely to have diagnoses of hypertension, diabetes, things that may not be very well controlled and can lead to poor obstetric outcomes, of course, but also may create differences in our fertility services and to our outcomes. Now, I don't particularly care for the BMI marker as an assessment of health status, and it absolutely has some failings and fallings there. But, you know, higher BMI numbers are associated with irregularities to menstrual cycles or in ovulation, and that could lead to a delay in childbearing or conception. And higher BMI levels has been linked to lower birth rates when you look at our SART and our IVF data. So there may be something to it. It is not, you can conceive at any size, but it may have some attributing factors to it in lowering our outcomes. And then there are the structural barriers to healthcare. And what are the infrastructure things? And this was mentioned before. And, you know, Black and as well as Hispanic women having to travel longer distances in which to seek care. And also in that study that was done earlier, that was mentioned by Dr. Jain, he mentioned that there's an increase, the Black women were more likely to note difficulty getting in for appointments and, you know, taking off of work to make those appointments. And as you can understand, or as you can see, possibly if you have a position because of a lower educational attainment, it's probably more difficult to accrue PTO and some of those things compared to a more salaried worker or someone who has a higher educational attainment. So there may be multiple factors at play that are leading to the disparities that we see. I love that, you know, Dr. Komorowski gave this just great, you know, what can we do to prevent that? And definitely I want to open up the floor later, and I want to hear the discussion around, you know, how can we be intentional and how can we engage and be proactive in doing something about these disparities that we see and we've known for some time now.
Well, that was fantastic. And yes, there has to be a much bigger discussion of what do we do? We know it exists, but what do we do? And that, yeah, that's a whole other, that could be a whole other webinar.
Absolutely.
Solution piece, right? All right. Our next speaker, and thank you very much. Great talk. We didn't need slides. You were great. Regina Townsend is a internationally known infertility advocate and the founder of the Broken Brown Egg, a nonprofit organization that highlights the struggle that the Black community faces when navigating the reproductive healthcare system. Her organization provides valuable support and resources that empowers individuals and couples when trying to navigate this very difficult journey. She will be discussing how an organization like the Broken Brown Egg can positively impact access to reproductive health care in the Black community. So Regina, take it away.
Thank you. First of all, I'm just really excited about the information that was included because it fits so perfectly with what I'm going to talk about. And I can, if it makes it easier, I can share my screen and that way I don't have to.
Yeah, sure. I'll accept.
Yeah. Let me see. Can you see it? Because I also added some stuff because I realized that I didn't include a picture of my husband or my son. And that was, you know, I feel like I would get in trouble. I feel like I would get in trouble for not including them. All right. So as mentioned, I'm Regina Townsend. I'm the founder of the Broken Brown Egg. I have had the Broken Brown Egg since 2009. I'm also a librarian. I specialize in youth and teen services. And I have PCOS, hypothyroid, menorrhagia, pop, just the gamut of fun stuff. I've also been a foster parent, and I was eventually an IVF mom. So I was going to talk a little bit about what the broken brown egg is. I feel like we've got all the information about the disparities, and so I don't need to go into any of that. I can just kind of show you where this came from and why I started this organization. So these are actual screenshots from my Facebook that show when I just started to say, like, did you guys know how much in vitro is? We need to talk about it. And you can't see the comments, but oh my gosh, the things that people said in response that were like just completely insensitive, that speak to that fact that many people of color had no awareness that Black women dealt with this at all. I also included a picture of when I did tell a doctor that I felt like I had PCOS, and she didn't agree with me, and I had to find a new doctor. So these things launched my advocacy. They kind of led to me starting to create my blog and just get my own thoughts out. So the Broken Brown Egg started as a blog, as seen here. I taught myself all kind of design and everything else just because I really wanted to be heard. I felt like infertility was stifling me. And when I was looking for representation, I couldn't find any that really spoke to my experience as a woman of color. I felt like most of the information and websites that I found were white women in a different economic status. And I didn't see anyone that looked like me, and that made me feel even more isolated. It made me feel even more as if something was completely wrong with me. But the more that I started talking about it, the more that I realized that it wasn't that we weren't experiencing it, it's that we weren't talking about it and we didn't understand that it affected us as well. So a year after I started the blog, my husband and I incorporated in the state of Illinois, and we held a gala to raise awareness about infertility. And the turnout just really solidified to me how many women really just wanted to be seen and understood in this space, not just about fertility itself, door down and just saying we're dealing with this topic, we would get many people that would message me, speak to my husband, that were just like, I didn't know anybody else was dealing with this. I didn't know Black people experience this. Where did you go? Who do you talk to? What do I do? And so we really realized that this was something we were going to have to continue. And it just kind of took off from there. I worked with just about anybody who reaches out to me and wants to help propel this conversation, because I believe that infertility is bigger than babies, which is what I learned along the way. I learned that it was my socioeconomic status, it was my mental health, it was my relationships, it was my faith and religion. It was intertwined into so many other aspects of my life. And that is represented in what, you know, the doctors just mentioned about how people of color, or specifically Black women and Hispanic women, have those additional barriers to their access to care, some of them being social. And so I decided that if representation was needed, I'm just going to keep talking about it and hopefully encourage more people to talk about it also. Some of the things that I learned over the years from having this organization is that it was difficult to advocate while also trying to navigate my own fertility. But I found that that was helpful for the people who were following me. People needed representation for them to get the courage or the encouragement to go to a fertility center, because in many cases, as was mentioned, fertility centers are not near where people of color live. So I'm in Chicago. Most of the fertility centers are not on the South Side where predominantly Black people live. So for me to travel to get to a fertility center was the only way I could get there. So being able to express to people where to go and how to find one, all of that stuff, and being transparent about my own frustration about it helped to encourage other people to pursue fertility treatment. I also have had to remind myself that after I've had all these years of learning about it, some of the things that I think are common knowledge are not still. So Henrietta Lacks and a lot of the other things that Dr. Greene just mentioned, I keep thinking everybody knows it, they don't know it. And so when we talk about Black and Hispanic women not accessing care, when it's self-directed and they don't go, it's like, well, just go to the doctor. And what we're trying to express is it's not as simple as just go to the doctor when historically we have mistrust that is valid. And so I've had to continue to remind myself that just because I know these things, there's still a huge number of the population that doesn't. And that's why this work is still so important. I've also had to learn how to encourage intergenerational learning about reproductive health. Many cases, people would reach out to me and say, I didn't know this was a thing until I was married, until I had been married for 5 years. I never knew that my extreme periods or my painful periods were a problem until I was trying to get pregnant. And I realized that it was partially, we weren't having these conversations with younger women. And I found that in my own family, that once I started talking about my fertility issues, older relatives started to say, oh, I experienced that, or, oh, I had a miscarriage, or I did IVF and it was unsuccessful. And I remember feeling like, I wish somebody would have said that at the beginning of all of this, then I would have had a little bit more understanding. And then another challenge has been redefining what success looks like in the infertility narrative. Again, I try to tell people all the time that it's bigger than babies. It is about so many other parts of what make a person have a high quality of life. And in this community, the success story has been successful pregnancy, live birth, when in many cases, we just need to be encouraging people that it's okay to pursue treatment, that it's okay to stop treatment, that it's okay to change doctors, all of those things. So redefining what success looks like has also been a challenge. And these are some of the messages that I get from people that are just, every time that I feel like, oh, there's no need for what I do, I get one of these messages where somebody is like, I really did not know there was anybody else talking about this. And I thought it was just me. And I didn't know how to put a name for what I was, words for what I was feeling. And that keeps me going. So today, the Broken Brown Egg is a 501c3 tax-exempt organization. I keep a resource library on the site for people to find other organizations that speak to endometriosis, fibroids, PCOS, that are Black or Hispanic led, so that people can see there are other people out here spreading the word in your community that look like you, that understand and have cultural competency. I also put fun things on there. So I've got music playlists, books, and other supports, because the topic of infertility is such a heavy one and a personal one that it can be shrouded in sadness and despair. And so I've really tried to encourage people that your journey is your journey, and you're allowed to be sad about this and also go to the movies. You're allowed to be saving for this because, as was mentioned, usually we're in a different socioeconomic status. You can be saving for this and also go buy that purse. Like, you're allowed to live a life. And the Broken Brown Egg also has a private support community called Shell Shocked, both on Facebook and attached to the website. So the 3 focuses of the BB, which is really cool because these are some of the things that the doctors mentioned today. We focus on reproductive justice and health equity. So making sure that there is representation, that we are speaking to the concept of reproductive justice, which is the right to have children and also to not, and health equity in terms of how to speak to your doctors, how to get a second opinion, how to make a complaint if you feel like you were disrespected or treated unfairly. What are questions you can ask when you go to the doctor? All of those things that speak to health literacy. We also focus on reproductive health careers pipeline. So This picture is of me and some of the physicians at VIOS, which is now Mindbody, at the Black Women's Expo here in Chicago, where we were just there to tell people this was a resource that was available to them, that fertility treatment was something that they could access. And also to tell them, we need more people that look like you to go after these fields, to pursue jobs in fertility centers, all of those things, because for people who don't feel represented, it means the world to us if we come in and even the receptionist is a person of color. And then empowerment and community. So I try to have events and opportunities for people to just feel like this thing doesn't have them, they have it, but it doesn't have them. And then we have a few signature programs. So every Mother's Day, we have a virtual wine sip Mother's Day support group where we just kind of talk. Sometimes I'll have a mental health professional or a cocktail that we all have the recipe for, but it's just something to give some encouragement during that day. We also do a lot of different virtual activities and events. So I've done Broken Brown Eggnog Night, cocktails and conversations. And generally those are opportunities for people to see people that look like them in a safe space where they can just be doing something fun, but also be around people who get it. And then, as I mentioned, the shell shock community and empowerment opportunities. So the empowerment opportunities are whenever I get a message from a media person, I post that question to the women and men in the shell shock group so that they can answer, so that they can be empowered to be the spokesperson for themselves. Or if there is a research study, we post those as well. So we're trying to get more advocates off the ground every day. And then this year we were able to give our first grant. So the Townsends are a couple from Georgia who applied. We had over 70 applicants, and they were our recipient this year. They are pursuing IVF in a couple of months, and we are super proud of them for being courageous enough to apply. And we're hopeful that we'll be able to do another grant next year. But here's the secret. There is no magic to the broken brown egg. I simply say what I wanted somebody to say to me. And I say it with cultural competence and transparency. Like that's really the it. It's not that deep. We want somebody who can make it okay to be not okay. Here are some of the type of posts that I do on the broken brown egg, which are really just sometimes notes to myself that I've chosen to share, because I always feel like if I feel this, somebody else has got to feel like this. Somebody else has got to feel like, I don't understand how to be facing a society where Black and brown lives are not treated with dignity and respect, but then also want to give birth to a new Black or brown life. Like those are questions that I have in my head, especially now as the mom of a Black son. Somebody else needs to hear that while they're trying to navigate their fertility challenges while also watching media and things that say that Black life doesn't matter. So what's the best way to provide equitable service? Basically, provide spaces and services and service models that invite us to be our authentic. Work well in this community? Or have you put a billboard over here? Or are you reaching out to the Black Greek letter organizations? Or are you speaking to the churches? Like, you need someone who can at least support you in reaching these underserved populations. And then really just telling my story has been the crux of the broken brown egg. That transparency has been self-care for me. It's also been helpful for other people to hear somebody else be honest about the parts that suck And the bravery that I think it takes, I didn't see it that way until other people started saying it. But when you look at these statistics that the physicians just explained, and then you look at the societal issues in conjunction with that, it does take a tremendous amount of bravery to say, this is what we're dealing with. This is what we went through. This is what we're doing. Or just, I'm not okay. And so I encourage people daily to share their story, even if it's just inside our private support group, or even if it's just saying something smart back to that relative who always has a question about why you don't have kids yet. Those little things are empowering. And the more that they add up, the more grassroots advocates we build. And the more that we have that, and people are talking about this in just normal conversation, I believe the better outcomes we'll have in terms of people pursuing care, having equitable service, and having positive outcomes. And then the last thing, which I didn't include in my slides, was speaking to the fact that things are so spread out, depending on where you live, that don't address different racial backgrounds. Partnering with local organizations so that there's like a pop-up where you can come and get your AMH checked, or having being participants at local libraries. All of those kind of things help to spread the word about the fact that reproductive health is health. Thank you.
Fantastic. Oh my goodness. What a way to end this webinar. It just was, you guys were fantastic. And there were a couple of comments and questions, and one of the questions that came up from one of, I guess, someone who's watching this webinar was about the LGBTQ community and why didn't we include them. And unfortunately, this webinar was concentrating on socioeconomic and racial disparities. And there was actually previous webinar back in June during Pride Month where we specifically discussed those issues. So that's why we didn't bring it up today. Obviously, we wouldn't have the time anyway, because that's, again, a whole separate conversation. So I just wanted to clarify that for anybody that's listening to our webinar tonight, that we didn't purposely exclude anyone, but this is just concentrating on a specific topic. So I think Judith, are you still here? I don't know if she's still here. She just wanted to make
I'm
some
here.
comments.
Is my picture off? Sorry. Oh, no, I'm here.
Wanted to make just a quick
Yeah, I
comment.
just wanted to quickly share with you the story of my client today, who's a Hispanic woman who got married at age 22. She's now 37. She's been trying to have a family for 15 years. She lives 3 hours from the closest fertility clinic. Her husband's a farmer, and she actually works for a physician, but she has no fertility or health insurance whatsoever. And so she told me today that she basically works just to cover the cost of fertility care at the 3-hour away fertility clinic. She has had several ectopic pregnancies. She has had numerous pregnancy losses, 10 failed in vitros. And she has never been offered or suggested to have an egg donor. She's never been suggested to have a surrogate. She called me because her cousin offered to be her surrogate, her cousin in another state. And she just keeps trusting that the fertility clinic will help her, even though she's had no positive outcomes. She can get pregnant, but she can't stay pregnant. Her HCGs go up quite a lot, and then they just fall off the planet. And I can't tell you how my heart broke for her today for many reasons, because of her story, because I'm a nurse and I want to take care of her, because I'm an attorney and I suffered through infertility and knew enough to change direction when I needed to change direction. And she just doesn't know. And she has fallen through the cracks, and she really did break my heart.
Yeah, that's I mean, and it's bias. It's a bias in our, in the medical community, no question, no
And
question.
the one thing that she told me that killed me as well is she said, I said, have you regrouped with the physician? And she said, what does that mean? And so I told her what it meant. And she said, oh no, she said, I haven't seen a physician for a year. And she said, when I have a loss, I speak to a physician on the phone, but it costs me $100 to have that conversation. And she said, I just keep working to pay for fertility care. And she says, I'm going to save up again. I've got one embryo left, but in October, I'll have enough money saved at age 37 to go through egg retrievals again when she's had all of these losses with her own egg conceived embryo. So again, I was just heartbroken for her.
Probably one of many, many stories, right?
Yep.
Does anybody have any other comments or questions before we wrap this up?
Hey, Althea, this is Christina. I hope you can hear me, but I have a question for Regina. I have a specific question. You know, in breaking down barriers and access to care and the underlying mistrust, what do you feel, you know, you talk a little bit about representation. How do you feel that trust can be built with providers when there has been such a history of mistrust?
Ooh, that's a big one. Some of it is partnerships. So in this space, there are quite a few of us now. When I started the Broken Brown Egg, it was really just me and the Cade Foundation. But now there is myself, there's the Cade Foundation, there's Fertility for Color Girls, there's Indo Black, there is the White Dress Project, which is fibroid. There's so many of us. And the difference that I've noticed in Black influencers, I hate that term, in this space, is that we are working our regular jobs and doing this, and we don't have the same funding and support that other influencers, if we use that term, or even nonprofits receive, particularly until there's something big that happens. And then it's like, oh, let's find the Black people. So I think reaching out to these organizations that currently exist, finding out what projects they are already working on and how to get them in the door to the population that you're trying to reach. That's how you build the trust, is providing opportunities to bridge your patients with the people they already trust. And that in turn tells them they can trust you because you're not going to be trying to do it. You're just getting out of the way and providing the service. I think the other thing is to not shy away from those historical contexts. When we look at the history of gynecology in this country, it's literally born on the bodies of Black women and poor women. Specifically, when we speak of J. Marion Sims, who did horrendous experimentation on Black women to develop many of what we see as now modern gynecology without anesthesia. We can't shy away from those things. When I was at ASRM last year, and it was in Baltimore where Henrietta Lacks is from, and there was no mention of her. And I just found that was ridiculous. We have this woman whose cells have led to the very thing that we're here talking about, and no one's going to go put some flowers down. No one's going to acknowledge. So I think part of it is not shying away from the hard conversations, and then making sure to connect with those who are already doing the work so that they receive the recognition and in many cases, the financial support to continue doing that work.
Fantastic answer. And you're right, building bridges is probably one of the most important things that I don't think we do enough. You know, we're physicians, we do our work, we forget about other things that should be incorporated into, you know, what we do every day and how we treat our patients. Thank you very much. Anyone else? Let me see, yes, so we're going to wrap this up, and I want to thank again everyone for joining. I just want to remind everyone that this is going to be, has been recorded, so you can, at your leisure, go ahead and watch it. So again, thanks again. Lovely to meet all of you. Have a good night.
Thank you.